Welcome back guys. Now let's discuss about loop of Henle. Okay, we have completed the topic of proximal convoluted tubule. Now let's discuss about the loop of Henle guys. See, now this loop of Henle is actually divided into three parts. Descending limb of loop of Henle. Okay, this is the proximal convoluted tubule. Okay, this is the PCT. This is the last part of the PCT. Now this is the descending limb of loop of Henle. Now this is the hairpin turn. Okay, this is the hairpin turn, and this is ascending limb of loop of Henle. Now this ascending limb of loop of Henle is again having two parts. One is thin ascending limb and thick ascending limb. Okay, thin ascending limb and thick ascending limb. Now, when the fluid is coming down from the cortex, from the PCT, now this fluid or the urine, the primary urine, now it is coming down into the descending limb of loop of Henle. So what happens? See, this descending limb of loop of Henle, first point is this descending limb of loop of Henle is freely permeable to or highly permeable to water. So water will move from in to out. So water reabsorption is happening in descending limb of loop of Henle. Now you will get it out. So first of all, why the water is getting reabsorbed? Why the water is getting reabsorbed? Now we all know that wherever there is sodium, water follows the sodium. See here, in all this area, see exactly right now I am pointing. See, this is actually the medulla. Okay, the descending limb of loop of Henle, where it is going? The descending limb of loop of Henle will go into the medulla. Especially I am now talking about the juxtamedullary nephrons. See, in the juxtamedullary nephrons, the loop of Henle will go deep into the medulla. The first point about the medulla is medulla will have hyperosmolarity or more concentration. Medulla have hyperosmolarity. What does I mean by hyperosmolarity? Normal plasma concentration. Okay, normal plasma concentration. Okay, or the osmolarity of the blood, I should say. Okay, the normal blood osmolarity is 300 milliosmoles. Okay, that's the normal concentration of the blood. But the concentration in the medulla is having hyperosmolarity, means more sodium is there, more chlorine is there, more salts are there. So all the medulla, this is all medulla. Now in all the medulla, what happens? In all the medulla, now there is hyperosmolarity. That too, when you go deep into the medulla, osmolarity increases. See, this is the part of medulla which is near to the cortex, for example. Now in the cortex also, same 300 milliosmoles is there. Now when you are going deep into the medulla, here it will become 600, it will become 800, it will become 1000, and it will become 1200. So when you go deep into the medulla, the osmolarity increases, the concentration increases. This is something called as corticopapillary gradient. In the cortex it is 300, in the tip of the papillae somewhere over there, in the deep inside the medulla, it will be 1200. So corticopapillary gradient is seen, which means when you are going deep into the medulla, the concentration actually increases. Now this hyperosmolarity, the sodium ions, okay, they will attract the water, they will suck the water. So water is going towards the hyperosmolarity. Okay, as the water is going out, what happened to the urinary concentration? See, when the urine comes here, outside more concentration is there. Okay, the urine, whatever is entering into the descending limb of loop of Henle, it is going to have a concentration of 300 milliosmoles. Okay, same. Now 300 milliosmoles is coming down here, coming here. Now here it is 300 milliosmoles. Now what happens? Outside it is 600. So what happens? Now water will be reabsorbed. Now here it will become 600, equilibrated. Now the 600 will come down here. Now here it is 800. So furthermore water is going to be reabsorbed. Okay, so as the urine, as it is moving down in the descending limb of loop of Henle, the urine is getting concentrated. Okay, because only water is getting reabsorbed via the aquaporin 1 channels. So here, now water is getting reabsorbed with the help of aquaporin 1 channels. Now this aquaporin 1 channels are reabsorbing the water. Okay, via the aquaporin 1 channels, the water is getting reabsorbed. Okay, so descending limb of loop of Henle is freely permeable to water. But in this descending limb of loop of Henle, any sodium is getting reabsorbed? No, no sodium, no chlorine, no calcium, no magnesium, nothing. The descending limb of loop of Henle is impermeable to solutes, Only water is getting reabsorbed. As the water is getting reabsorbed, the urine is getting concentrated. So the descending limb of loop of Henle is called as concentrating segment for the urine. It is concentrating the urine. So it's a concentrating segment for the urine. Okay, now we will get it out. See, water is getting reabsorbed. Where does all this water will go? Now all this water will go into the blood vessel. Okay, all the water, we don't want it in the medulla. We don't want it in the medulla. All the water will be reabsorbed back into the systemic circulation. Okay, water will be reabsorbed. Now, at the tip of the papilla, two important MCQs. Now, in the medulla, what is the concentration? Hyperosmolarity is there. How much hyperosmolarity? 1200 milliosmoles. Deep inside the medulla, the medullary concentration is 1200 milliosmoles. And in the tip of the loop of Henle, what is the urinary concentration? Yes, 1200 milliosmoles. Now, this urine is going to come into the ascending limb of loop of Henle. First, this urine will go into the thin ascending limb as well as later into the thick ascending limb. Okay. Now, first of all, let's see some important points. Yeah, descending limb of loop of Henle. Yes, it is only permeable to water. Okay, water is getting reabsorbed via aquaporine 1 channels. Yes, and the descending limb of loop of Henle is impermeable to ions. We have discussed, and it is called as the concentrating segment. It is known as the concentrating segment of the urine. Yes, urine is getting concentrated. True. Now after this, let's discuss about the ascending limb of loop of Henle. Okay, ascending limb of loop of Henle. Now please appreciate, now the fluid is moving like this. Now it came here, now the urine start to go in the ascending limb of loop of Henle. Now what is happening in the ascending limb of loop of Henle? See, now this is one epithelial cell. This is one epithelial cell in the ascending limb of loop of Henle. Point is, the ascending limb of loop of Henle is only permeable to solutes, freely permeable to solutes, which means solutes are going to be reabsorbed but not the water. Only solute reabsorption, no solvent reabsorption or no water reabsorption. Ascending limb of loop of Henle is impermeable to water. Okay, having said that, see, now sodium, chlorine, potassium, everything is coming like this. Now here on the luminal surface, this is the epithelial cell. Okay, this is the epithelial cell. Now, on the first let's start with the basolateral membrane. Now on the basolateral membrane, please appreciate, okay, there is this one transporter present. What is the name of this transporter? The name of this transporter is sodium potassium ATPase. Okay, it's a sodium potassium ATPase. Sodium potassium ATPase is present on the basolateral membrane. Okay. Now on the luminal membrane, this is the luminal membrane. No, on the luminal membrane, which transporter is present? On the luminal membrane, sodium potassium 2-chloride symporter is present. Okay, it's a sodium potassium 2-chloride symporter. Now, if you ask me, what is the sodium potassium 2-chloride symporter? Please appreciate. Now, it is reabsorbing sodium, one sodium ion and one potassium ion as well as 2 chloride ions into the cell. So, sodium, potassium, 2 chloride ions are entering into the cell. So, sodium, potassium 2-chloride symporter. Okay, sodium, potassium 2-chloride symporter. Now, sodium ions are coming into the cell. Okay. Potassium ions are coming into the cell. Okay. And 2 chloride ions are also coming into the cell. Okay. Now, there is no problem for the sodium. See, sodium is coming into the cell and the same sodium will be getting out of the cell. Okay, now sodium enters into the cell and that sodium will be pumped into the interstitium. Yes, we have discussed, right? The medullary interstitium is hyper concentrated, hyperosmolar, more sodium is there. Now, from where that sodium is coming? See, via here. So, sodium is going to enter into the cell and the same sodium is going to enter into the interstitium. The same sodium will be going into the interstitium. So, with the help of sodium potassium ATPases. So, sodium enters, sodium leaves the cell. Not only that, see this chlorine, okay, whatever is getting entering into the cell, see this chloride ions, okay. Now, chlorine enters into the cell and the chloride also going into the interstitium, okay, it's also going into the interstitium. Why? Because, yes, even chloride channels are there, sodium channels are there, chloride channels are there, so sodium is going into the interstitium, even chloride is getting into the interstitium. But problem comes with the potassium ions. See, potassium is coming into the cell. Okay, sir, well and good. Now, what is the sodium potassium ATPase is doing? Now, the sodium potassium ATPase, it throws 3 sodium ions out, okay, but it is bringing 2 potassium ions into the cell. See, potassium is coming into the cell, okay, potassium is coming into the cell via this route, as well as potassium is going into the cell via this route. So, what is happening? Potassium is getting accumulated. Potassium is being accumulated into the cell. Okay, potassium is being accumulated into the cell. Now, we don't want an extra amount of the potassium. No, we don't want it. Okay. Now, what happens is potassium, we will discuss in a minute. But anyway, see, when the urine is going like this in the ascending limb of loop of Henle, now from the urine, the solutes, see, the solutes are being reabsorbed. The solutes are being reabsorbed. Okay. So, when you take out the solutes, when you take out the salts from the urine, what happened to the urine? Urine is getting diluted. Okay. No water reabsorption. Water is not getting reabsorbed. Okay, only you are taking out the solutes from the urine. So, urine is getting diluted. So, that's why the ascending limb of loop of Henle is called as a diluting segment. It's called as a diluting segment. Now, let's talk about the fate of this potassium. What happened to this potassium? Now, look at this image, guys. So, what I am saying you, in the ascending limb of loop of Henle, these epithelial cells, they have more amount of potassium. Now see, potassium from these cells, they will start to leak. Now they are getting secreted back into the lumen. Now from these epithelial cells, now potassium is getting back, okay, it's getting back into the ascending limb of loop of Henle. So because of the secretion, okay, because of the secretion of this potassium, now potassium is a positive ion. Okay, now potassium is a positive ion. Now potassium is being secreted into the ascending limb of loop of Henle. That actually gives the positive luminal potential. So ascending limb of loop of Henle is having which potential? Positive luminal potential. So what we are discussing? We are discussing that potassium is getting accumulated inside the cell, and the potassium is going to be secreted back into the ascending limb of loop of Henle. That gives the positive luminal potential. So now tell me, ascending limb of loop of Henle is having positive luminal potential, and what is the importance of this positive luminal potential? See, this positivity will repel the divalent cations. See, now calcium and magnesium. Now the calcium and magnesium which are getting filtered. Okay, the calcium and magnesium, they will come down like this. Okay, now this calcium and magnesium are the divalent cations. They are the divalent cations, not just normal cation. They are having so much positivity, 2+. Okay, it's a 2+. Now, whenever these divalent cations, whenever they are coming down into the descending limb of loop of Henle, hairpin turn, and whenever they start to ascend up, okay, whenever they start to come into the ascending limb of loop of Henle, what happens? Now the positivity here in this lumen, now this positivity will repel the positivity on the calcium and magnesium. So now the calcium and magnesium, do you think this calcium and magnesium ions, they will start to go into the ascending limb of loop of Henle? Is it possible? No. Now the calcium and magnesium will be reabsorbed back into the lumen via the paracellular route. In between the cells, there are these gaps present. Now via the gaps, now the calcium and magnesium are going to be forced to go into the interstitium. Why? Because the calcium and magnesium cannot go into the ascending limb of loop of Henle. Why? Because the ascending limb of loop of Henle is having positive charge. Okay. So this ascending limb of loop of Henle is called as, yes, diluting segment. Okay. Now let's see this important point. Ascending limb of loop of Henle is having positive luminal potential. Why the positive luminal potential? It is due to potassium ion secretion, which is helping in the absorption of calcium and magnesium via the paracellular route. Okay, via the paracellular route. Now after this, let's have a little pharma link. Okay, let's have a little discussion about the pharma. Now guys, have you ever heard about this loop diuretics? Okay, loop diuretics acts on the loop of Henle. Which part of the loop of Henle? Ascending limb of loop of Henle. Now in the name itself it is there, see, loop diuretics. Diuretics means double the urination, more urination. They will cause more urination. Diuretics are the drugs which causes some more urination. How they are going to cause the more urination? In a simple way, we can say something like this. See, loop diuretics are the drugs which are going to act on the ascending limb of loop of Henle. The examples of the loop diuretics includes furosemide, torsemide, bumetanide, ethacrenic acid. All these are the loop diuretics. Okay, all these are the loop diuretics. Now what they will do? How they will cause a diuresis, double the urination. Okay, how they will cause a diuresis, more urination. How means? This diuretics inhibits sodium potassium 2 chloride importer on the ascending limb of loop of Henle. On the ascending limb of loop of Henle, yes, there is this transporter present, sodium potassium 2 chloride importer. That sodium potassium 2 chloride importer is going to be inhibited. Whenever the sodium potassium 2 chloride importer is inhibited, see, the sodium potassium 2 chloride importer is the most important transporter which is sending the solutes, into the interstitium. Okay, now the medullary hyperosmolarity is mainly because of the sodium potassium 2 chloride importer. Now whenever the sodium potassium 2 chloride importer is inhibited, means now the sodium ions are not getting reabsorbed, chloride ions are not getting reabsorbed. Now all this sodium and chlorine is going to lost in the urine. Wherever water goes, sodium follows. So all the sodium will be lost in the urine. So water follows the sodium. So there will be diuresis. Okay, in a simple way. Not only that, see, whenever you block the sodium potassium 2 chloride importer, okay, now sodium is not going into the cell, potassium is not going into the cell, chloride ions also not going into the cell. So potassium, first of all, important point is potassium is not going into the cell. So intracellular potassium levels does not increase. So potassium is not going to be secreted back. Okay, what we have discussed previously. Now, usually potassium ion accumulation will be more inside the cells, so that potassium secretion will happen into the ascending limb of loop of Henle. So whenever you block the sodium potassium 2 chloride importer, potassium is not entering into the cell, so potassium does not leak out of the cell. So positive luminal potential is going to be neutralized. The ascending limb of loop of Henle is going to lost its positive luminal potential. When the positive luminal potential is lost, what happens? The calcium and magnesium are not going to be reabsorbed. Now this calcium and magnesium are going to lost in the urine. They will be lost in the urine. So calcium reabsorption decreases. Okay, calcium reabsorption decreases. All this calcium will go into the urine. All that urine will collect in the renal pelvis, from there into the ureter. Now in that urine more calcium is there. Now this calcium will precipitate and it will form stones. So one of the side effect of the loop diuretics is nephrolithiasis. Okay, and what loop diuretics are doing to the calcium? Loop diuretics loop out the calcium from the body. Okay, it takes out the calcium from the body. Okay, why? Because positive luminal potential is lost and calcium reabsorption and magnesium reabsorption decreases. So calcium, magnesium is going to appear in the urine. Now this calcium will precipitate and form stones So we know loop diuretics takes out the calcium from the body. So it can be used in those conditions wherever there is hypercalcemia. So in the conditions of hypercalcemia, if the patient is having lots of calcium in the body, you need to take out that calcium from the body. Okay, so if you want to take out the calcium from the body, you can use drugs like loop diuretics. Okay, yes, we have discussed loop diuretics. What they will do? They will block sodium potassium 2-chloride importer on the ascending limb of loop of Henle. And see, there is this one disorder which is called as a Bartter syndrome. Now what is happening in this Bartter syndrome? In Bartter syndrome, sodium potassium 2-chloride sympathers. So, okay, sodium potassium 2-chloride sympathers are mutated. So in loop diuretics, same transporter is mutated. Okay, not mutated, same transporter is inhibited. Loop diuretics inhibits sodium potassium 2-chloride sympathers. And there is this one syndrome which is called as a Bartter syndrome. Okay, by birth it will be there. Now this Bartter syndrome, what is happening? The sodium potassium 2-chloride sympather is mutated. It is not functioning properly. If it is not functioning properly, what happens? Same symptoms. The patient is going to lose the calcium out of the body. The patient is going to lose the magnesium out of the body. More diuresis is there. This baby will be suffering with the dehydration. The point which I want to put into your mind is this Bartter syndrome. It resembles what? Now in Bartter syndrome, it resembles loop diuretic overusage. Why? Because in Bartter syndrome and loop diuretics, same transporter is inhibited. In both the conditions, the same transporter is getting affected. So the features, the clinical features of Bartter syndrome are similar to that of loop diuretic overusage. Okay. So now let's discuss some important points about the Bartter syndrome, guys. Now Bartter syndrome, it's also called as, okay, hyperprostaglandin syndrome. Okay, hyperprostaglandin syndrome, like, in this syndrome high levels of prostaglandins are there. This is just a medicine integration. Okay, very important topic for your exams, Bartter syndrome. Now it's Bartter syndrome. Later we'll discuss about the 𝐒𝐮𝐻 syndrome. Okay, most of the kidney related disorders are autosomal recessive disorders, but there is one syndrome which is called as a Liddle syndrome. Okay, Liddle syndrome is autosomal dominant. Though it looks like little, this is not something little, this is dominant. Okay, so Liddle syndrome is autosomal dominant, but rest of all the others are autosomal recessive. Okay, Bartter syndrome is autosomal recessive. Okay, well and good. Now Bartter syndrome, it resembles what? It resembles loop diuretic overusage. Okay, it's a loop diuretic overusage. And what are the clinical features in this Bartter syndrome? The clinical features are, see, Bartter syndrome, sodium potassium 2-chloride sympathers is inhibited. So sodium is not getting reabsorbed. When the sodium is not getting reabsorbed, all the sodium is going to be lost in the urine. Sodium is going out in the urine, water follows the sodium. So more and more urination, excessive urination, diuresis is there. Now that diuresis in this baby, all this is happening in a baby. Now that diuresis in this baby is going to cause dehydration. Okay, polyuria, excessive urination. This patient is suffering with dehydration. So, and these patients are also having failure to thrive. Severe dehydration is there. Okay, failure to thrive. And if you look at the BP is decreased, or it can be normal. Okay, it can be normal or it can be decreased. Why? Because there is volume loss. More and more urine is going out of the body. More volume is getting lost. So what happened to the BP? BP is normal, or most of the time it is decreased, but it is never increased. It is never increased. Why? Because later we will say there are certain kidney disorders where BP is increased, like Liddle syndrome. In Liddle syndrome, BP is increased. There will be hypertension. But here the main problem is polyuria, dehydration, failure to thrive with normal or decreased BP. Okay, BP is never increased. Here, see, the sodium potassium 2-chloride channels are mutated, right? On the ascending limb of loop of Henle, sodium potassium 2-chloride channels are defective. Not only that, the chloride channels in the ear, okay, the chloride channel in the ear are also defective in this condition. As the chloride channels in the ear are also defective, that will cause sensory neural hearing loss. Okay, sensory neural hearing loss. So this patient, this baby with the Bartter syndrome, okay, this baby, this neonate is going to have sensory neural hearing loss. Along with the sensory neural hearing loss, this baby is also having dehydration, polyuria, failure to thrive. Okay, all these things are seen. Okay, BP is decreased or normal, and this baby is, as he is having severe dehydration. If you look at the anterior fontanelle is actually depressed. Okay, see, if there is like more volume, anterior fontanelle is going to bulge out, but this baby is like having dehydration, right? Dehydration, no volume is there. So if you look at the anterior fontanelle is also depressed or sunken anterior fontanelle. And what about the increased calcium levels? Okay, increased calcium levels. See, this patient is having increased calcium levels. Why this increased calcium levels? Where? Point is where increased calcium levels? Increased calcium levels in the urine. Okay, increased calcium levels are there in the urine because loop diuretics. Loop out the calcium. In Bartter syndrome also, same transporter is affected, sodium potassium 2-chloride importer is affected. So calcium, where it is going? All this calcium is going out in the urine. In the urine, calcium is going to precipitate and forms the kidney stones. And calcium is going out of the body, so bone formation is not going to be good. That causes rickets. Okay, that causes rickets. So this is called as a renal rickets. Kidney problem causing the rickets. So renal rickets is there. Okay, renal rickets. And what is the investigation of choice? Sodium potassium 2-chloride importers. The chloride ions are effective. So all the chloride is going out in the urine. Okay, so sodium levels, sodium levels are going to be increased in many conditions and sodium levels will be decreased in many conditions, but chloride is something specific. Now, what is the investigation of choice is looking at the chlorine levels. Okay, in this Bartter syndrome, sodium, potassium, 2-chlorine, everything is getting leaked in the urine, but important is the chlorine levels. Now, chlorine levels will be elevated in the urine. So, the urinary levels of chlorines is elevated. The urinary levels of chlorine is elevated. 24-hour urine. The urine levels of chlorine is elevated, and the drug of choice for this condition is indomethacin. Okay, the drug of choice for this condition is indomethacin. Why? Because these patients are also having high prostaglandin levels. Now, in order to decrease the prostaglandin synthesis, you can use the drugs like indomethacin. You will discuss more about the Bartter syndrome in the medicine classes. Anyway, so with this, we are done with the topic of loop of Henle. We have seen descending limb of loop of Henle as well as ascending limb of loop of Henle. Hope the video is helpful. Thank you.